Hello and welcome everyone to this grand rounds on mental illness in the criminal justice system. This is a cooperative effort with the psychiatry departments of University of Toledo, the Ohio State University, and the Attorney General's Task Force on Criminal Justice and Mental Illness. My name is Dr. Jeffrey Hunter. I would like to give you a little bit of an introduction, how we got started on the Grand Rounds project. This was originally started by Justice Eve Stratton of the Ohio Supreme Court. And the idea was to present knowledge, awareness with the integration of the justice system and mental health community for medical students, psychiatry residents, and for that matter, even practicing physicians. When when Justice Stratton retired from the court, she formed the task force on the Attorney General with the Attorney General, who was at that time Attorney General Mike DeWine, and that task force was on criminal justice and mental illness. Part of what they did is they took over this project for Grand Rounds, and that has been continued under Attorney General Dave Yost as well. Specifically, the Psychiatry and Treatment Committee of that task force has taken up the reins to do that. I was a former co-chair of that particular committee. Now I'm the special advisor to that committee. Without further ado, we'll get started. I did just want to make sure and thank Dr. Niedermeyer of the Ohio State University Department of Psychiatry and her team for hosting this and recording this so that it can be used in the future in our training programs. We see that our objectives are up there to identify challenges to effective treatment at the intersection with criminal justice, mental health, describe the role of special courts such as mental health courts and judicial collaborations with the community, understand the importance of crisis intervention teams and their training. I'd like to now pass it on to Dr. Victoria Kelly to start our first presentation. Thank you, Dr. Kelly.
Thank you. Hi, everybody. And a quick word of for everybody, if you have any questions, you're welcome to type them in the chat or in the Q&A section. So after we're done talking, we've reserved some time at the end to answer some questions. So feel free to type away if any questions come up. So I've been involved in medical education for quite a while, and the intersection with forensics also. It's one of my passions. So doing this has been a really great honor. Question for you guys. What % of adults in the US have a mental illness? The answer is 20%. Now let me ask you, what % of Ohio's jail inmates have a mental illness? And that one is a little higher at about 50%. So you can see why this is a problem in society and for us as professionals. And that intersection with law enforcement becomes particularly tricky because most officers are not adequately trained. There's laws that protect civil liberties, but it make it difficult to involuntarily commit or treat individuals, making it way easier to just arrest them. And if you consider the statistic that about 1/4 of all fatal police shootings involve a person with a mental illness, I mean, that's pretty horrifying. So I want to take you through this scenario briefly. A patient is homeless, non-adherent with psych meds, hallucinating the devil's voice, and delusional that he's Jesus and he's not sleeping. And he steals a coat. So where does the officer take him? probably to jail. The only options are an emergency room, a psychiatric mental health crisis center, or jail. Right now, that's it. And so just a quick recap to remember that with any crime, there's two components. There's a physical commission of the crime, or in Latin, the actus rea, or the mental state behind it, the mens rea. And so it's not like we know who did the crime physically. So the question is a mental state. So this is where a lot of things get tricky for us. And this algorithm that you see here represents what happens to an individual with a mental illness who has committed a crime of some sort. We'll talk a little bit more about the mental health courts later. But the important thing to realize is that a jail is not a psychiatric hospital, and it's vastly different. So if we go back in time a little bit, the first psychiatric hospital was established in 1773, a long time ago. This photo is Dorothea Dix. She was born in 1802 in Maine to a traveling preacher father and a mother who had some sort of illness. And so basically she had to take care of her two younger brothers. 1821, she founded a school. 1831, she founded another school. But she had some pushback. It was the women's education movement. And so she ended up being too stressed. She went to England. This is important because while she was there, she was introduced to leaders in prison reform and mental health advocacy. And then she came back to the US. 1841, she taught some female convicts in jail. And that's when she learned that poor women with mental illness were sent to jail because there was no one to care for them. And they basically got no treatment and were physically abused. So then in 1843, she submitted a petition to the Massachusetts legislature, which was successful in getting more funding for state asylums. The next year, she did it in New Jersey. And over 15 years, she traveled North America campaigning for well-funded facilities where care could be provided to those who could not otherwise afford it. And overall, she helped establish or expand more than 30 institutions. So overall, she was pretty important in our history of psychiatry, and she was a critic of these cruel and neglectful practices. Caging, incarceration without clothing, using very painful physical restraints. And she advocated for moral treatment developed from the work of the French psychiatrist Pinel. And if you keep in mind, by the height of deinstitutionalization in 1955, about 500,000 people were living in these state-run psychiatric facilities. So let me ask you this. So then what happened in 1954 that helped speed up deinstitutionalization? So take a minute to read through these. Was it journalist undercover, Nobel Prize, antipsychotic, new technique for ECT, Community Mental Health Act, or Medicaid and Medicare? So mentally take your vote. And the answer is C. It was Thorazine. So going through these just briefly, the first one is 1887. The journalist wrote The Snake Pit. And in 1927, that was for the Nobel Prize for treating syphilis. So the answer is C, Thorazine. It was FDA approved in the United States in 1954. It had been first made in France as an antihistamine and a pre-anesthetic, and they found that the people who they gave it to, they were super calm without losing consciousness. And so this allowed for a significant shift in psychiatric care because, lobotomies and ECT wasn't the only, they weren't the only options. Just FYI, the Community Mental Health Act is very important. It's also has been called the Mental Retardation and Community Mental Health Act. That was in 1963 by President JFK, and it provided federal funding for community mental health centers and research facilities. But only about half of those proposed centers were ever built, and none were actually fully funded. And the act didn't really provide the money to operate them in the long term. And choice F there, Medicaid and Medicare was enacted in about 1965. So again, just a little more history. And one last thing before we go into some more of the current things is the Penrose hypothesis. So as the number of psychiatric, that there's an inverse relationship. As the number of psychiatric hospitals beds goes down, the size of the prison population goes up. And so instead of a deinstitutionalization, what happened was just institutionalization at someplace else or a trans institutionalization. They've done some studies since then. Some have backed it up, and most are kind of equivocal, but I think it's a really interesting thing. Also, if you look at just straight up the numbers, as the number of hospitalized individuals has gone down, the rate of incarceration has gone up. And so I think when a lot of the issues that we're facing now, they're not new, but they've definitely become an issue stemming from this. So instead of going to the proper community mental health and to, warm, loving, embraced families with full funding and all of this, people ended up in the jail, homeless shelters, nursing homes, dumpsters, or dead. And in 44 states, a jail or prison holds more mentally ill individuals than the largest remaining state psychiatric hospital. And individuals with schizophrenia or bipolar disorder are 10 times more likely to be in jail or prison than a hospital bed. So I bring this all up because we have multiple systems that are involved with care of these patients, right? We have the medical system, we have the behavioral health system, the addiction and recovery system, and then the criminal justice system, which has several other wings to it too. So given all of these systems issues, there's a lot of pieces to this puzzle of advocating for appropriate mental health care of the people that are affected by it, which leads to opportunities for every single one of us to really be able to make a difference, even in that little area that we can. So for me, I'm heavily involved with medical education with med students and residents mostly. And physician advocacy is actually one of the core components of the umbrella of professionalism. It's kind of undefined, but all physicians do meet it at some level because we do try to help stand up for our patients to get their needs met. One definition of advocacy for physicians, it's an action done to promote social, economic, education, and political changes that ameliorate the suffering and threats to human health and well-being. And so what do we think about advocacy? We may think, well, I already do this on the individual level. Like I do medication pre-auths all the time, or I already like I'm in support of civic engagement, but like maybe I don't have the time or energy to do it. And what they've actually found is that a physician is more likely to do this if your personal experience and morals aligns with it. Advocacy can look like a lot of different things, though. It could be meeting with other collaborating stakeholders. It could be, talking to legislators, and it can be done on the macro and micro level too. So as we overlap with the criminal justice system, we absolutely have patients, all of our patients in some way, will have been touched by the criminal justice system in some way. 1 in 4 people with mental illness have a history of a police arrest. And usually it's going to be misdemeanors, just like trespassing or assault or maybe drug related. But police may use a disorderly conduct charge to arrest an ill person if they can't figure out any other charge, but they understand that this person is ill and needs some sort of help. So what ends up happening is it frustrates our law enforcement, colleagues, and that they see a lot of the treatment as a revolving door. But consider this, incarcerating individuals with severe psychiatric disorders costs about twice as much as enrolling that patient in a assertive community treatment program. So it saves money, but in that moment, it becomes really difficult when safety, is at risk. Another flip side, besides just psychiatry and criminal justice, is actually like emergency medicine and primary care and the trickle-down effect because, our patients have diabetes, high blood pressure, and they're users, frequent utilizers of the emergency room. And so if you look at the literature about what is considered a difficult patient in medical scenarios, it is about 15% of adult patients in primary care. And what happens though is that so many of our patients by default of their illness already meets these criteria. So they have a presence of depressive or anxiety symptoms, more somatic symptoms. Their symptoms are more severe. They don't get well. They have a lot of problems. They don't take their medications. And so another entire category is increased legal and or ethical issues. And we deal with that all day. So a part of what I encourage participants to this webinar today is to just kind of take away that on an individual level, we can do things. And that is to try to help the patient, meet them where they're at, and try not to contribute to a difficult patient encounter. So that physician characteristic side, that will make things worse. And coming from a place of knowledge and empathy. We do have also a shortage of mental health professionals at correctional facilities. Trainees don't often rotate through correctional facilities. So how do you know that you want to do it if you've never really been exposed to do it? And that intersection with the law too. But heads up, if you're in psychiatry, the ACGME actually has a competency of requirement that you need to know the legal aspects of psychiatric practice. And besides just like, oh, are you going to go kill someone right now? Like the imminent homicidality, it's besides that. So what we have in today's society is the criminalization of the mentally ill. So deinstitutionalization led to that. Some of the outdated treatment laws have led to that or contributed. We have some funding issues with like Medicaid, for example, and just an overall lack of funding to really fully support some of the ancillary services that would help with, the wraparound with patient care. And the problem is that nobody benefits, but everybody pays. So I encourage, why you should care. Well, besides the fact that you are a physician or future physician or someone with a professional duty, that it really does contribute to worse health outcomes for individuals who have legal outcomes, legal issues. So we can't help that society has stigma, but we can help to not be ignorant about the things that are going on. So for trainees, I recommend knowing how to have an open and empathic conversation with someone about their legal issues. Avoid stigmatizing language, and just understand some of the vocabulary that goes on with the legal system. Also, legal history can influence your treatment decisions sometimes. And the probate side of things is an entirely different beast outside of the scope of today, but definitely understanding that intersection with the law. So here are 3 simple questions that you can incorporate into patient interviews. Have you ever been arrested? Right? You're not saying, have you committed a crime? Have you ever been arrested? Are you currently dealing with any legal issues? It could be anything. Could be bankruptcy, but it could be, assault or having to meet with a probation officer. And have you ever had any legal charges due to alcohol or other substances? Again, the language is neutral and open. And then just understand the differences and what some of these things might mean, because there's nothing a patient, likes more if their doctor has no idea what's going on with them or no idea of, what they're going through. So familiarizing yourself, open-ended questions, that's really what I would recommend, because as physicians and other behavioral health care providers, we are pretty important link in the chain of their care. And, just because you have a mental illness does not mean that you don't have a life goal to have a fulfilling profession, to get married, have kids, whatever it is. And that intersection with the law can make things a lot more difficult if something ends up going through. So I encourage everybody to become involved, step up and ask more questions and be open to that collaboration. So that's the end of my portion. I'm going to pass it off to Dr. Smith.
All right, thank you much, Dr. Kelly. So I'm going to take us to a sort of a systems approach. I appreciate that discussion and some pointers for those newly entering the field as well as those who are in the field. So I'm going to talk about what's called the sequential intercept model, a MAP. The M is really MAP, actually created by my predecessor here at the Summit County ADM Board and former chair of Neomed Psychiatry, Dr. Mark Munitz, along with Dr. Patty Griffin. Next slide. And we can just skip to the next one, that's fine. So way back in time, back in 2001, I was actually still working for the Ohio Department of Mental Health at the state hospital system before ODATIS and ODMH had merged. And they actually created this concept of coordinating centers of excellence. And one of the ones was designated to be at Neomed at the time, I think Neo-UConn, but at Neomed. that was around criminal justice. And you can see their logo at the bottom there, the Ohio Criminal Justice Coordinating Center of Excellence. They have become the leaders in coordinating the likes of CIT, Crisis Intervention Team, training across the state, which CIT actually first started here in Akron and Summit County and spread across the state with a lot of help from many, many people. I'll have a slide that'll show you many of those players. And it's formalizing it through the CJCCUE. They're also, amongst other things, the people that hold on to the sequential interstep model and help facilitate it across the state. And every year they are able, through some funding, to actually come out to different counties and do these maps. So I'm going to describe it quickly here for you due to time's sake. But to give you a sense, this might be something you would be interested in doing or redoing. We've actually now done it several times over the decades in Summit County, and it really does help you hone in on what to do to try to avoid having your jail become your largest mental health provider in your county, because as Dr. Kelly said, that's a real issue nationwide. Next. So here's a slide with some of those players on it, and a lot of them are around there. PEGS Foundation, so there's private funding as well. For example, they happen to be located here in Summit County, based on a family that has a adult son, I think actually around my age now, with schizophrenia, who's doing very well, but they also had trouble navigating the system despite having pretty good wealth years and years ago, and got a lot of help through NAMI Ohio and others, and they became very interested in funding these types of programs and system approaches. You see Justice Stratton there as well, who wasn't able to join us today, but often gives the introduction in these types of talks, and she's been instrumental in all the things I described, the CIT, Valor Court, and now a lot of the work that's done through the Attorney General's task force. Next. So here is a simple version of the model. The original model actually was published as more of a funnel, or if you will, a filter system. And it did get worked on by people at the Gaines Center, and they ultimately adopted this more linear model. But the reality is, of course, we know that it can wrap around. And part of the point of this is to help individuals wherever they hit the part of the system, to maybe never go back through the system again, to help keep them at what's called Intercept 0, and I'll show you that in a second. But while we're on this slide, Intercept 1 starts with the community, right? This is why CIT is so important across Ohio and now internationally. Again, starting in Ohio. It's spread across the country. There was an initial creation of this in Memphis, Tennessee, and I think at the time it stayed in Tennessee and came to Ohio starting in 2000 through Lieutenant Mike Woody from the Akron Police Department. ADM board paid for him to go to the 40-hour training, and that spread. That was picked up also at the time by Justice Stratton, by my predecessor, Dr. Mark Munitz, Dr. Fred Fries, who many of you know is an amazing person with schizophrenia, former captain in the Marine Corps, but amazing advocate as then a psychologist who went around literally lecturing in all 50 states about stigma and some of the things that Dr. Kelly already touched on, as well as this model, how do you get to find a solution in your system. So you see the Intercept 1, I mentioned it. Now, of course, 988 has been added to this because that's another component of this whole system, and how to get 988 and 911 to be interoperable, to communicate, because the public isn't always going to know which number to call, but we really want no wrong number. So if they call one and need the other, or vice versa, there's systems that are being worked on now at the state level. I know we're working on it also in our county to try to make those seamless, and not by putting anybody on hold in a crisis. And then Intercept 2, okay, so you have had an arrest because that's going to happen. Well, what else can we do there? Maybe the person doesn't need to go all the way toward a path of jail or even potentially eventually prison. And so that's where you put new places in there. You know, can you do this? Can you do some initial hearings? Can you make sure the judge and the bailiff are aware that mental health and or substance use are part of the mix? Maybe there's another option that we can use at that point for this individual so they don't end up being put into the system that's includes incarceration and some mental health services, but not often as many as might be in other settings. Intercept 3 is the jail. There are specialty courts. Judge Heath is going to talk to you about one such specialty court in a few minutes here. And then you get into Intercept 4. So now we're getting out of the jail or the prison. So you've got both types of reentry. What can happen there? Over the years, OMAS, soon to be the Department of Behavioral Health, they have a linkages system. Those individuals do actually go in and do talk to the people at the jail, the mental health teams. I used to work, full disclosure, at the Toledo Correctional Institute for about 10 years, part-time, treating individuals there, all male, high close security, just below maximum security. And linkages by the end of that would be helping them to come out and get established back in the community, to give them some of the supports they need, again, so they don't continue on this cycle, because our ultimate goal is always to give people back their autonomy and remain in the community and have recovery and a full life, be productive citizens and so forth. Then you move into Intercept 5, which is the community corrections. If you looked at a big chart of how many people are in prison or jail versus how many are out on probation or parole, Intercept 5 is way larger because people stay on that penitentiary for years, particularly on parole coming out of prison, and that's a big part of their life at that point. So obviously we want to make that as positive as possible so there's no reoffending, which can be tied to mental illness, right? So we really need to work on both of these at the same time. Next. Okay, and I think I've done enough of this. Let's go on to the next one. So here's the Intercept 0. This was actually added back in 2016. You see that, so the Gain Center is involved in the background, Policy Research Associates also involved then and now. And you can see that they added Intercept 0 to the model because it became very clear that the more we can do in the community before there's an arrest, before law enforcement, even well-trained CIT officers and now even CIT paramedic firefighters are called to the scene, what can we do differently? So crisis lines, 988 has arisen out of this Intercept 0 concept. More of a continuum of services before anybody ever related to mental illness, maybe not exactly always due to it, so it's not always NGRI, not guilt by reason of insanity, but in mental illness is part of the picture, and the person isn't able to necessarily comply with laws in the same way. They come to people's attention, and unfortunately what happens sometimes is the person is unable to control themselves in the face of an officer. They struggle, they resist arrest, they may even assault an officer, and now they're fully in it. Now that's a felony. Now they've moved into this system. The CIT has greatly decreased those occurrences and other things that are done in everyone's continuum of care, all of your agencies that work in substance use and mental health care, and obviously that intersection, very, very important. So Intercept 0 has been a good addition to the model. Next. So I'm just going to quickly just give one example of the mapping system, just so you've heard it a little bit about it. You can see the map is the big deal. It's a day and a half usually. A full day, you bring in something in the order of 35 people representing the whole system. Ideally, at least one consumer and one NAMI family member are part of that, as well as the jail and law enforcement and judges and so forth. Some of your agencies represented. And you walk through the system and you identify the gaps. And then that night, the team from NeoMed, the Criminal Justice CCOE, they will put all that together. They have a very long evening usually, putting all that together, and then they bring it back the next half day, and you sit down and you really go through the exercise of identifying, okay, what are we going to prioritize to work on? We can't do all the gaps at once. What are we going to prioritize? And then from that come usually some subgroups that meet, and then of course action plans to actually make a difference in wherever they identify issues. Next. So here's the objective, right? All these individuals I just described come to the table. Try to limit it to about 35 people or so because it gets unwieldy. But having a larger group, not 10 people, having a group like 35 lets you have some subgroups to then work on each of the priorities. And I'll give you an example of that in a minute. Next slide. So here's one that we did in 2016. Just to give you a sample of this, you can see the white boxes were added to this after we had our big meetings. Where are the gaps? Where are the good things that are going on? And then we did have a series of meetings with we actually had a subgroup from each of the intercepts. Once a lot was accomplished through that in our county, and then we actually did meetings of intercept 1 and 2 together and intercepts 3, 4, and 5 together, because there were even gaps in between the intercepts, right? So that's just an example. Then we redid it again recently. Next slide. So in the next model, so we just did this almost exactly a year ago now. Same idea, different players, right? We had some changes. The sheriffs knew from the prior sheriff in 2016, et cetera. So we got together again, large group of people, about 35, I think it might have been 38 people this time, and we walked through it again. We said, okay, what's working? What's new? So for example, in Intercept 1, you see Scout. That is our Summit County outreach team, which actually just started that March of 2024. It's still going strong. It's been a phenomenal team of a CIT trained Akron Police Department officer, CIT trained Akron firefighter paramedic, and a clinician. Actually, the main initial clinician we also had go through our 40-hour CIT class, just because she could see, in that case it was a she was able to see exactly how the officers and paramedics were being trained. So, that's one example of the many. For time's sake, I won't go through this, but it gives you a sense of how, look at the many things there. A lot of these are new. They're not the same as on the prior slide, because we have new items going on. 988 is new. That was not around in 2016. It's only recently had its 3-year anniversary, July 16th of this year. And other things were added along the way, more interventions in the jail, things that really made a difference and still make a difference in trying to break this cycle and get people the help they need, and then keep them in the community, not in jail, not in hospitals, certainly not in prisons. Next. So here's this. I got this from Neomed. It's actually on their website if you want to see it. This is from all the mappings they did from 35 different Ohio counties up through 2024, and you can see the range. Notice that at the top is crisis. Right, we all talk about the crisis systems. There's a lot of discussion around mobile crisis teams. We chose to take the crisis out of ours and call it Scout, but other counties have simply called it mobile crisis units and so forth. A lot of screening, the next one that comes up, screening and a lot of information and data sharing. We are heavy data driven, as you all are, so we have to really rely on that now. How do we make things better? Well, we look at outcomes, we measure data, and then we cycle back, which is why we did our intercept mapping yet again, because we really needed to see where we could move on the topics. So when you get done at the end of your day and a half, normally you have usually 3 or 4 topics, and you can see the top 3 or 4 that often show up are the same ones that show up on this list of priority themes, but you may be the county that's got the bottom 4, but they're still important. If your people in the system have identified that that's the ones to work on, and they may take a year or 2 to work on to really make a dent. Some of these are, as they say, the wicked issues, very big, tough issues that aren't just solved by people talking, right? A lot of action. Next. So in our jail, just a real quick thing to give you our personal example. Again, some of this has come out of our mappings over the years. That mapping in 2024 was our 3rd mapping. I only showed you 2 of them. We actually even did a mapping specific to the opiate epidemic because we thought that model worked, and it helped us a lot in our continuum of care for dealing with the opiate epidemic, which sadly is not gone, but harm reduction, Narcan, Suboxone have made a huge dent, and overdose deaths at least have decreased substantially. So you can see here in jail services, we do a lot that goes beyond the minimum jail standards, which still is what's used in the nationally as well as in Ohio. We now have all MAT, for example, Vivitrol, Methadone, and buprenorphine in our jail. That took a lot to get all 3 of those there. It's not inexpensive. ADM board pays for all of that. In our county, there is some money that comes back through the Attorney General's work, so we appreciate that very much, and wish that had been expanded in the budget, quite frankly. The mental health medications, of course, very important. How do you make sure you've got psychiatry time, potentially even psychiatric nurse practitioner time in some of the jails? And then, of course, there's connections to our crisis intervention team. We do train our deputies as well. for that. And then a lot was really being added, even as we speak, as more and more peer support to that. Then I'll mention, I put on your courts, as I said, in a few moments here, Judge Heath will talk about mental health court. Next. So again, in the jail, just real quickly, are not new anymore, but Sheriff Candy Father, she's the newest one, ran immediately, hit the ground running. She's a champion. We now have meetings, a team of meetings with the sheriff, the county representatives, ADM board, the mental health provider in the jail, who we fund entirely, and the physical health provider, but they need to work together because integrated care is the only best care. And we meet at least monthly, but actually in recent months, it's been every 2 weeks to really get this to work, to make this better and better and better. We have one agency that has stepped up for 15 years at least now, Summit Psychological Associates. They do wonderful work. The pharmacy support is there, peer support, as I said. We do a daily report from the jail. We run the data at ADM because we're HIPAA protected, and then we can notify the agencies who, it's actually done electronically now. It's pretty much automated finally. That took some doing, but every day, so our big agencies know if they have a client who's ended up in the jail. Otherwise, they might not know that for days or weeks because the person may be very ill, but has allegedly committed a crime. So they end up in the jail. This allows them to have immediate contact with Summit Psychological Associates and give the patients the best care possible, inmates if you prefer. But I think basically from our perspective, they're patients getting the care they need. And then we've arranged, finally, it used to be that discharges happened all times of the day. Sometimes they were sudden, they'd make bail. Other decisions were made that were not part of the clinical team, and they were discharged and they didn't leave with their antipsychotic, or they didn't get their Vivitrol shot that we wanted them to get on the way out the door, to hopefully buy them a month buffer as they got more into the outpatient care, for example, for an opiate use disorder. So a lot of this has gotten much better in the recent years, and part of that came out of even that 2016 mapping model. Next. So the last thing I'll say, and then we'll move on to Judge Heath, is the Thrive House. This is a great other program. Again, Sheriff Fothery, ADM, Community Support Services, one of our excellent agencies here, put together the Thrive program inside the jail. Summit Psychological is in charge of that in the jail. And that led to last year, August 13th, opening of the Thrive House. Phenomenal addition to the continuum. This is a house, you can see some pictures at the bottom there of the living space, that the individuals can now, they're identified, they have to agree, it's all voluntary. They're in the Thrive program, and a small group of them with the most need can go into this 14-bed facility for 30 to 90 days and get rehabilitation, and really, I believe, often habilitation. They've not learned any of the skills of living because of their mental illness going on. They never learned how to make a budget or to shop for food and healthier food, etc. So just a final piece I'll say there. Next. Here's some resources when you get the slide set. Next. That's my contact. If you have questions about any of this, very straightforward. Next. And now I'm very happy to introduce the Honorable Judge Heath. Thank you.
Can you hear me now? Great. Good afternoon, everyone. I'm Judge Taryn Heath. I'm with the Stark County Court of Common Pleas, and did a stint for the Ohio Attorney General's office and was, it says my internet connection is unstable. Can you still hear me?
Yeah, you froze for a moment, but you're back now.
Okay, great. Where I represented a 5-county area to do civil commitment hearings to what was Massillon Psychiatric Center, now known as Heartland Behavioral Health Care Center. And so I saw mental illness up close and personal during those civil commitment hearings, and had a real compassion for those. Next slide, please. When I became a judge in 2007, my predecessor had a mental health track. I'm really very cognizant of the impact of stigma, and I try to do everything I can to reduce stigma when I'm on the bench and when we're doing programming. So I changed the name of the mental health program to the HOPE program, which is an acronym for helping offenders psychologically and emotionally. And another component of the way we deal with folks with mental illness is our Veterans Treatment Court, which I named Honor Court. And then another component is a program known as Intervention in lieu of Conviction. These different programs are crucial for maintaining the processes that keep those with mental illness out of our jails and prisons, making sure that they obtain housing, engage in treatment, maintain treatment, and successfully complete a probation. Those are the goals. Next slide, please. First, I'd like to talk about our HOPE program. This is a huge collaboration, including law enforcement, providers, and court employees. We meet regularly. It's a multidisciplinary team to assess what's going on in all of our respective areas, how we can collaborate better and problem solve in making sure the individuals that we are dealing with are getting the services and attention they need. So, for example, from the law enforcement sector, we have probation officers who are specifically assigned to a caseload of individuals with mental health issues. We have a representative from Stark Regional Community Corrections Center, and that is what we call a community-based correctional facility. It's not a jail, it's not prison, it's something in between. For example, in Summit County, it's Oriana House, and they have them all over the state. But some individuals are sent there as an alternative to prison, and it's important that while they're there, they're getting their mental health meds and they're getting their treatment and therapy as well. So we include them on our HOPE team. Of course, the Stark County jail staff, as Dr. Smith said, it's really important to have a sheriff that's on board, and our jail is, or our sheriff's department is actually in the process of building a brand new jail, and there is going to be a specific mental health wing there because unfortunately we find, folks with mental health issues being incarcerated as a result of deinstitutionalization. And then the Canton Police Department actually has an officer who is a mental health liaison, which is really great. And he tracks police calls that are crisis related. And so they know when a call goes out for a particular individual or maybe a residence that we may need to employ our mobile ACT team to that particular police call. We also collaborate with StarkMar, which is our local mental health and addiction recovery board, and their forensic liaison is a member of our team. We have staff members from Heartland Behavioral Health because there's always issues in pink slipping somebody from either the jail or SRCCC or from a police department arrest to Heartland. So we like to keep in touch with them. And then Summit Psych, who is very instrumental in Summit County, also has offices and case managers and clinicians in Stark County, and that's who we use for our HOPE program as well. And then we also include our Developmental Disabilities Board because we do get a lot of, not a lot, we get a fair amount of individuals who are intellectually challenged that come into our justice system. So we feel it's important to include that agency as well. And then I have presided over the HOPE program for many years, since 2007. I am looking towards retirement, and so I am actually co-chairing it now with Judge Haupt, a benchmate of mine, because it's very important to plan for transition. And we have our deputy court administrator and our honor court director on our HOPE program. It's really important to meet frequently with everybody who's involved in supervising and or treating folks with mental illness to make sure that we all know what each other is doing and how we can improve. Next slide, please. So talk a little bit about Stark County Honor Court, which is our veterans treatment court. And you can see our tagline is reclaiming honor, dignity, and lives. I'm really proud. We are certified by the Ohio Supreme Court. We also employ a multidisciplinary team approach that utilizes ongoing judicial interaction. I have honor court twice a month. Every participant I talk to, make sure that they're being accountable to their programming, keeping up with their treatment, and getting some positive reinforcement from myself and our team, and every once in a while, some tough love if they're straying off course. The one thing that I call one of the most important aspects of our Veterans Treatment Court is our peer mentoring services. We have volunteer veterans from our community who peer mentor our participants. They're there every court appearance, and they keep in contact with our participants in between court appearances to make sure that they are adhering to our requirements and are being supported in between their court appearances. I also am especially focused regarding creating community connections for our veterans by providing pro-social activities and getting them connected with our veteran organizations in the community. And the way we do that is they're required to perform 100 hours of community service as a condition of their participation in the program, but they can get double community service hours if they do that to benefit a veteran or another veterans organization. It's an incentive, and then it gets them connected. The other thing we do is each participant before they graduate is required to do a community give back project that benefits a veteran or a veterans organization. Most of our participants are dual diagnosis. We see a lot of PTSD, traumatic brain injury, a lot of addiction. And so a lot of times I'm dealing with both mental health issues and addiction issues. And all of these services that we provide deal with each individual on an individual basis. That's extremely important that we have individualized treatment plans. So we require every participant to have a mental health evaluation and a substance abuse evaluation. And we are a treatment court, so they have to adhere to their treatment plan. We do reassessments along the way if someone has slipped or fallen in some way. And we're really proud of the success that we enjoy. We have like a 5% felony recidivism rate and a 68% success rate. Actually, I think that success rate is higher recently. Traditional probation is only about 25% felony recidivism rate. So 5%, if anybody knows anything about recidivism rates, ours are literally off the charts successful. And we're very proud of that fact. Next slide, please. It's important for every member of the judiciary to establish and maintain excellent community connections. We have a community corrections planning board where people can reach out. It's collaborative, and you have to identify the community resources that you have. For example, NAMI, I'm trying to think, the housing agencies, the food pantries. We keep lists of all this stuff, where all the AA meetings are. We provide all this information to our participants because we can't do it on our own. You need your community agencies to partner with. And that's how I see the judiciary's role in supporting folks with mental health issues that find their way in our criminal justice system. Happy to answer any questions anyone might have or any feedback. And now I think we're passing it back to Dr. Hunter.
Thank you very much, Judge Heath. I will say I've been with the Attorney General's task force, I think, pretty close to its inception through Justice Stratton, who is amazing when it comes to this. In that capacity, I've had the pleasure and honor to chair several of the or some of the committees, one of which is a veterans committee, and I did have the honor of co-chairing that with Judge Heath, and she is an amazing individual on her compassion, innovation, and commitment. One of the main reasons I think Justice Stratton asked me to give this presentation is I'm not only a physician, but I am a law enforcement officer. I have been a law enforcement officer for nearly 30 years. And I am also a CIT trained officer and have taught in CIT program as well. You heard a lot from Dr. Smith in terms of CIT. It was developed in Memphis in 1988. In 2000, as he said, between Dr. Woody and Justice Stratton, it came to Ohio, one of the early adopters as it went, as it spread. And I think one of the main things to point out is this is the so-called Memphis model. It's a 40-hour training program. It combines mental health education, effective police tactics, de-escalation skills. And what's very important is, and if we go to the next slide, it brings together the entire community in mental health along with law enforcement. Law enforcement officers, like it or not, they've become first responders in many cases for mental health crises. I think that's changing, and we're working to get that changed. The education itself, just so you know, it goes over, it's pretty thorough. It goes over what are mental illnesses? What's the basis of them? This is truly something that involves an organ, the brain, and this isn't as though people act, quote, crazy and they can do something about that just by deciding not to, and tries to address those types of that type of stigma and misinformation and misconceptions out there. There's also training in active listening. And here's what I was talking about, the collaborative effort, so important. While there's standardized curriculum with CIT in terms of presentation of what is mental illness, et cetera, it's very community specific because the officers need to know what is it that's available in their community system when they have somebody in the midst of that mental health crisis. There's state coordination you see there, and you see that it's even gone international. Next, please. Now, as Dr. Smith said, NeoMed is Criminal Justice Coordinating Center of Excellence. They provide the crisis intervention coordination in the state. They're celebrating their 25th year. Next slide. And next slide. I'm sorry to rush through these, but you will get these to be able to read in more depth. CIT is, and if we could hold that slide, CIT has been expanded not only to law enforcement, but to EMS, 911, of course, 988 get very specialized training, and correctional officers. We're spreading this as we go through the different intercepts, if you will. You can see there how many sworn officers have been trained in CIT. Next slide. There's just a map for your viewing pleasure that you can see pretty much, in fact, all 88 counties have trained CIT. Some of the larger police academies actually have it incorporated to their regular training. Next slide. And thank you to NeoMed for that information. There's a contact there. Next slide, please. And open for questions. I put a few references there for you. All right. Questions?
I believe we are out of time. So everybody will be able to get access to the slide deck and a video link to today's presentation. Feel free to reach out to any of us and we can coordinate that. Thank you, everyone.